Hello students. Hello students. Today's our topic is delirium. So what is delirium? Delirium, it is also comes under central nervous system disorder, or it is a one type of brain disorder. So it is most common behavioral disorder in medical surgical setting. So in this, the acute mental status changes which will be characterized by abnormal or fluctuating attention. Means in this delirium disease, the person is having the problem of mental status changes, and mental status changes, the characteristic which will be showing that the patient is showing abnormal or fluctuating attention. There is disturbance in level of awareness, means the person is not having fully awareness, or the person orientation which will be also decrease, and reduce ability to direct or focus on any object or anything, and sustain and shift attention, or impair cognition. Means delirium, it is a one type of behavioral disorder, and in this basically it will be creating the mental status changes in the brain, and it will be occur because when the patient's brain which will be having any disturbances in the function. Then what is the definition of this delirium? So delirium is a syndrome of acute confusion marked by period of waxing and waning level of consciousness, altered psychomotor behavior, and perceptual impairment. Means it is a syndrome means it is a group of symptoms in which the person is having the problem of marked confusion. Means the person is having the problem of acute confusion, and it is a period of waxing and waning which will be level of consciousness, and it will be altered the psychomotor behavior. Means in sometime in central nervous system disorder, the person is not having the behavioral problem, but in this disease basically the person is having the problem of psychomotor behavioral problem and perceptual impairment. Then what are the altered psychomotor activity? So in altered psychomotor activity, there are two types of delirium. So first is the hypoactive hypoalert subtype, and second one is the hyperactive hyperalert subtype. So first is in hypoactive hypoalert subtype. Hypoactive means the activation of that person which will be decrease, and the alertness which will be also decrease. So it will be occur when the person is having the problem of psychomotor retardation. When the person is having psychomotor retardation, or in this the person is showing lethargic, means the person is feeling always feeling uneasiness, and the person is always having the problem of decreased arousal. The person is not able to arouse properly, means the arousal which will be decreased. The person is always feeling sleepy. Then hyperactive hyper alert. So in the second type of delirium, the person is having the problem of hyperactive. That particular person is having hyperactive and hyper alert. Means when we will compare with the normal person, so means with normal person, the hyperactive, that delirium patient which will be hyperactive or hyper alert. So in this, the first is the agitated means feeling or appearing troubled or nervous. Means the person is having the problem of troubled in nervous system, or feeling that overactivity of the ANS. Then likely to have delusion, means the person is having delusion or perceptual disorder, like the person is having hallucinations, and in this only about 15% are strictly hyperactive. Means basically the person is having the problem of this hyperactive. It will be in delirium, it will be in 15% only, which will be strictly hyperactive. Then patient being younger, then drug related causes. And when the person is having the problem of hyperactive, it will be occur because of this drug related causes. Then shorter hospital stay, when the person is having hyperactive or hyper alert, in that time the patient's stay in the hospital which will be shorter. And in this, when the patient is having the problem of hyperactive, hyper alert, delirium, in that time the patient is having better prognosis as compared to hyperactive or hypo alert. Then what are the etiological factors which will be comes under this delirium? So first is the infection which will be occur in the brain when the patient is having any type of infection which will be creating the abnormality in the function of the brain. Then some drugs like long acting benzodiazepines, meperidine or propranolol or scopolamine or H2 blockers. So these drugs which will be directly affecting the function of the brain. So if the person is taking long acting benzodiazepine or these all drugs, it will be affecting the function of the brain, and because of this it may be developing the chance of delirium. Then next is the withdrawal stage. What do you mean by withdrawal stage? Withdrawal stage means when the person is withdrawing anything, मीन्स जब वो किसी चीज को विड्रॉ करता है. सो अल्कोहल विड्रॉ, व्हेन द पेशेंट इज suddenly withdraw the alcohol, in that time it will be affecting the function of the brain. Or benzodiazepine drugs or meprobamate drugs, so the person's brain which will be affecting. So because of this, the person is having the problem of delirium also. Then hyperperfusion means when the patient when in brain the reduced amount of blood flow, when the brain is not getting the sufficient amount of blood, so in that time the brain is not able to do the proper functioning, and because of this the function of the brain which will be affected, and the person may be developing the chance of this delirium. Then next is the hypoxemia means it will be reduce the amount of oxygen in the blood. So when the oxygen level or the oxygen level which will be decreased in the blood, so in that condition also the brain which will be not getting the sufficient amount of oxygen. So in that condition the brain is not able to do the proper functioning. It will be affected the function of the brain. Then next is the malignancy में paraneoplastic phenomenon. Pain means malignancy, how it will be affecting if the patient is having any malignancy or any malignant which will be present in the brain or any part of the brain. So it will be compress that particular area, or compress that compress particular area of the brain. So when that particular area which will be compressed by that malignancy, so the patient's brain which will be not able to do the proper functioning because of the it sometimes it will be affecting the neurotransmitters or any part of the brain or any lobe of the brain. So in that condition also the patient may be developing this delirium. Then next is the electrolyte abnormalities, how it will be affecting the function of brain when the level of the electrolytes which will be increase or decrease, it will be affecting the function of the brain. For example, if the sodium or calcium level which will be increase or decrease, so it will be, or magnesium level, it will be affect the function of the brain. And sometimes when it will be severely increase or severely decrease, so it will be affecting the function of the brain, and because of this the patient is showing the psychomotor activities. So because of this also the patient is having the problem of this delirium disease. Then next is pain post-operative or fecal infection or urinary retention or fracture. So in these condition, if the patient is having the pain, so why the pain which will be responsible for causing the delirium, or it is a one type of risk factor? Because the pain which will be related to our brain means the pain transmitted from the brain means we have already studied this pain in second year. In that we have we have already studied about that gate control theory. In that we see in dorsal horn of the spinal cord the pain which will be controlled. So it will be also affecting the function of the brain. Then endocrine problems. The patient is having hypothyroidism or hyperthyroidism, hypo or hyperglycemia. So in that time also the patient may be developing the chance of this delirium. Then sensory deprivation or sleep deprivation or physical restraint. These are the etiology of this delirium. Then the age factor, it will be also affected the function of the brain. So the age over 80 years and male sex are independent risk factor for the development of delirium in hospitalized patients. So the age is also a factor. Then an underlying history of dementia, that is Alzheimer's, vascular or multi-impact, is the most significant risk factor for the delirium of for the development of delirium. The next is pathophysiology. So the pathophysiology of delirium is not entirely understood, but some points may be may be involved in this pathophysiology. So first, brain areas may be involved. Some areas may be involved because of etiological factor. Some alteration in neurotransmitter because of any etiological factor, it will be affecting the neurotransmitter, and some alteration which will be occurring in the neurotransmitters. So when any alteration which will be any alteration which will be creating in the neurotransmitter, it will be altered the blood-brain barrier permeability by cytokinase. So when the alteration which will be occur in the blood-brain barrier, so in that condition, the abnormal secretion of melatonin which will be present in the brain. So when the melatonin, it is an abnormal secretion. So when the abnormal secretion which will be secreted by the brain, in that condition it will be showing some symptoms or group of symptoms. So delirium is the final common pathway of many pathophysiological disturbances that reduces or alter the cerebral oxidative metabolism. Means it will be also disturbances or that reduces the, or it will be alter the cerebral oxidative metabolism. Then next, what are the symptoms which will be present in the patient who are having the problem of this delirium? So first is hyperactive. Sometimes the patient is having the problem of hyperactive. We have already discussed about the type of delirium. There will be two types. So first is the hypoactive or hypoalert, and hyperactive or hypoalert. So in that we have already seen about we have already discussed about this symptoms, and sometimes the patient is having mixed symptoms. The patient is showing mixed symptoms. Then a study of 325 patients in a general hospitalized identified 15% incidence of hyperactive delirium. Means the incidence rate of hyperactive delirium which will be 15% and 19% hypoactive, and 52% which will be mixed type. Then what are the diagnostic scale and criteria? Basically, the diagnostic scale that will be related to psychiatric. So confusion assessment method, then delirium rating scale, then memorial delirium assessment scale, a 10-item scale designed to quantify the severity of delirium in medically ill patient. These all scale or the method in third year you have already studied in psychiatric subject. The delirium symptom interview may not be distinguished delirium from dementia. The Nilon and camping confusion scale is widely used in the nursing community, which will be measures acute confusion rather than delirium. So these are the diagnostic scale and the criteria which will be used in the patient who are having the problem of delirium. So in medical surgical, what we have to done in a laboratory test. So first is the EEG, electroencephalogram. It changes the virtually always accompany delirium. It disorganizes of the usual cerebral rhythm. Means what we will see in the electroencephalogram, we will see the electrical impulses which will be generated by the brain, that will be normal or abnormal. When it will be abnormal, when the brain is having any abnormality or any injury or any infection or any trauma or any tumor, in that time the electroencephalogram which will be generating any um, abnormal impulses, then means EEG frequency or degree of slowing correlates with the degree of delirium. If the frequency or the degree of electroencephalogram which will be slowing, it will be correlates with the degree of delirium. Then additional EEG patterns from intracranial causes of delirium include focal slowing, asymmetrical delta activities, and paroxysmal discharge. Means these all findings we will see in the patient who are having the problem of delirium. Then periodic complexes such as triphasic waves and periodic laterizing epileptiform discharges may help in the differential diagnosis. The next diagnostic or laboratory test, that will be lumbar puncture and neuroimaging are needed in only a minority of delirious patient. The lumbar puncture should be proceeds by CT scan or MRI scan of the brain, as we have already discussed in etiology, that the etiology, that will be infection. So we have to uh, see that the patient is having any infection with the help of this lumbar puncture, and any this structural damage, it will be identified with the help of CT scan or MRI. Then other essential laboratory tests include complete blood count, glucose or electrolyte, blood urea, nitrogen, creatinine, transaminase, ammonia, thyroid function test, arterial blood gas, then chest radiographs, electrocardiogram, urine analysis, and urine drug screening. Then antibody test against HUR and NMDA receptors. So these are the other essential laboratory tests include. Then delirium or dementia. Delirium or dementia means in delirium it is a acute onset, and dementia it is a gradual onset. In next class we will discuss about this dementia. So in this slide we will only see that what is the difference between delirium or dementia. Then in delirium last for hours to week, means the delirium which will be last for hours to week, but the dementia which will be last for months to year. Then the patient is having the problem of mood swings which will be fluctuates worse at night, and swings which will be stable or sundowning. Then attention decrease of hyper alert, then normal attention span or alert in dementia. And in delirium language which will be incoherent or slow or rapid. Sometimes it will be slow, sometimes it will be rapid, so it will be very difficult for understanding their family member. Then word finding difficulty in dementia, the patient is not able to finding the word, means they will having the difficulty in finding the word. Then differential diagnosis of delirium, that will be delirium versus mania, delirium versus acute paranoia, delirium versus depression, or delirium versus psychosis. Then what management which will be used in the patient who are having the problem of delirium. So first is we have to providing with the analgesics drugs. So in analgesics, why we have to give this analgesics drugs? So if in brain there will be some changes or any other problems which will be arises, so the patient is complaining the problem of patient is having the problem of pain. So in that time we have to give the analgesic drugs. Then steroids. So if the patient is having the problem of any inflammation, so we have to give the steroids or corticosteroids drugs. So then we have to give the antimicrobial INH or gentamicin drugs if the patient is having any infection. Then next is the antihypertensive clonidine, methyl dopa or propanolol. Why we will give this antihypertensive drugs? Because in the blood, or when the patient's heart which will be not functioning properly, in that condition it will be also affecting the function of the brain. So in that condition we have to also give the antihypertensive drugs, or sometimes if the patient is having the problem of hypertension, so it will be also affecting the function of the brain, or sometimes the patient is having the problem of severe attack, then we have to give the drug anti-Parkinsonian drugs in this idopa or bromocriptine drugs we have to give to the patient. Then next is the digitalis. Digitalis, it is extracted from the, or it increases the force of the contraction of the muscle of the heart by inhibiting the activity of an enzyme. So we have to also provide the digitalis because sometimes the patient's brain which will be not getting the sufficient amount of oxygen or blood. So in that condition, we have to give this digitalis. Then psychotropics, we have to also give the psychotropic drug for the patient who are having the problem of this delirium. Then next is the drugs with excess potential for severe outcome in patient over age. So we have to give the analgesics over meperidine or respiratory depression and CNS adverse effect, example delirium. Then next, there are several steps in management of delirium. So first is find the cause, means what are the steps for managing the delirium disease. So first we have to find out the cause and we have to eliminate that cause. Then next is the symptomatic measures, because in this the disorder which will be having the group of symptoms. So we have to do the symptomatic measure involving attention to fluid and electrolyte balance. We have to see that the patient's electrolyte balance, then nutritional status, and early treatment. If the patient is having the problem of infection, in that time we have to providing the early treatment of infection. Then environmental intervention. The next is the reduced unfamiliarity by providing a calendar, a clock, family pictures, and personal object, because the patient is having the problem of orientation. So we have to providing calendar, clock, or family members picture, so the patient which will be recognize these all things. Then maintain a moderate sensory balance in patient by avoiding sensory overstimulation or deprivation. So we have to maintain a moderate sensory balance of the patient. Then minimize staff changes. We will not change the staff if the patient is having hospitalized or if the patient is in home. So if we are providing the nursing care for the patient, so in that time we have to not change the staff. So if we will changing the staff, so in that condition the patient which will be not able to recognize that particular person. Then limit ambient noises and the number of visits from strangers, means we have to limit the noise and we have to decreases the number visit from strangers, and we have to provide radio or television set, so the person's mind which will be distracted. A night light, we have to also provide the night light where necessary. We have to providing the hearing aids, because this disease which will be occur in old age person, so we have to providing the eyeglasses, we have to providing hearing aids. So then we have to also see the environmental measures, including providing soft music. We have to provide the proper care to the patient. We have to providing proper maintaining the proper hygiene, then allowing the patient to take walks when possible. Then physical restraint should be avoided. We have to always avoid the physical restraint if possible, and sitter used instead. Then proper communication and support are critical with these patients. So these are the several steps in the management of delirium. Then drugs with excess potential for severe outcome in patient who are having the age over 65. In that time we will give the antidepressant drugs. So in antidepressant drugs, what is the function of this antidepressant drugs? That will be inhibit the reuptake of a specific neurotransmitter, hence it will be increasing their levels, which will be levels around the nerve within the brain. So in this antidepressant drugs, tricyclic antidepressant, high risk of urinary retention, sedatives, and anticholinergic side effects. Then what are the medical management? We have to see the look for reversible medical causes outside of the brain that are amenable to medical treatment, and consult with family members about any other sign and symptoms which will be present in the patient who are having the problem of this disease. Then it helps to focus the extent of aggressiveness of diagnostic test and medical care. Then non-pharmacological management, we have to providing the proper nutritional support to the patient, aspiration precautions, we have to provide the proper comfortable position to the patient during the time of sleep. We will see that the patient which will be not aspirate the secretions, then we will provide the early rehabilitation technique for the patient, and no physical restraint. Then what are the prevention? The prevention of this delirium, it will be randomized trial of geriatric interdisciplinary team management in hospitalized patient at risk for delirium. So we have to providing the proper management. If the patient is in hospitalized, in that time we have to see that the patient which will be properly oriented or not. We have to make geriatric interdisciplinary team management in hospital patients, so it will be at risk for delirium. So in this way we will prevent from the delirium. So these all are about the topic of delirium. So thank you.